Thank you.
Very nice, President. Now we have Dr. Ananth. He's going to take us through the very, very important area of doing a YAG capsulotomy. I think that is, we need to know how to do it properly. Dr. Ananth.
Good morning, sir. First of all, thanks to ISCAR's team for including me in this symposium where routine procedures for general practitioners. I think each and every cataract surgeon would land up doing a capsulotomy. The incidence may vary from 20 to 30%. So there are some few interesting facts which we should know about PCO. You know, there is no specific size or dimension for this. It's like amoeba, it can take up any shape. Whatever the technology, whatever the IOL things have come up, but still the incidence is high. Higher the age, lesser the incidence of PCO, and diabetics, because of this collagen activity and all, the incidence of PCO is less. And incidence varies from center to center, and majority of the patients, almost 42%, undergoes a capsulotomy 10 years after cataract surgery. So as I told, it's like amoeba, it takes various forms. It's just a membranous thing behind the IOL. So when do we do a capsulotomy? Whenever our uneventful patients comes back to us with reduced vision, either in terms of quantity or in quality, or sometimes you need to do some post-assessment treatment, you are not able to visualize, yes, you require this. The contraindications, if you are not able to visualize the posterior capsule because of any optical issues related to cornea or nystagmus, it becomes absolute contraindication. The relative contraindication, any active inflammation or acute inflammation going on, cystoid macular edema, and high myopes where the risk of RD is there, yes, it becomes difficult. So how to prevent or postpone the onset of this thing? The video runs? Yes. What I personally feel is we need to follow things. Our rexis should be between 5 to 5.5. The edge should cover almost or 0.5 mm of the margin, so it gets postponed, and very good cortical cleave up is very, very important. PC polishing, some surgeons do recommend, but I personally feel that good cortical cleanup itself will work out very well to delay the onset of PCO, and good hydro dissection. And one more, personally what I believe is rotating the nucleus post hydro 3 times clockwise or anti-clockwise. That will release up all the equatorial cells, which are the future proliferative cells which causes the PCO. So these steps can be taken. The IOL factors, 6 mm, the square head technology, all this tries to prevent the onset of PCO. The angulations of optic angle also helps us. There are some other pharmacological ways, they are still in research level, not yet practical. So coming on to the YAG capsulotomy, we all know it's an 1064 and solid state, NDIAG, photo disruption. It produces the acoustic waves, it breaks down the capsule. So how to prepare the patient? You need to dilate the patient, done a topical anesthesia, obtain informed consent, because complications can happen, and make sure that you position the patient very well. They are sitting comfortable, because it may take around 30 seconds to 1 minute or so. You need to tell the patient to look into the fixation light with the other eye. So sitting position should be very comfortable. Video runs? Yeah. Adjust the chin rest height. Inform them it's done on a topical, shorter duration. Focus it well, preferable in a dark room. So what are the energies we use? Most of the times we land up using 1 millijoule. Identify the stress lines, give a shot at the tension line. Minimum 4 shots is enough, either Christmas tree pattern or crochet pattern. Make sure that you will not leave any residual tags. If it falls in the antechamber, it's better because it passes out through the angles. So this is the procedure. You can just see here, focusing is very, very important. I just give 4 shots. I think this has been recorded with the handheld device, again with iPhone. It's the clamp mounted. 1 millijoule, 4 shots. No residual tags are left out. It's a simple procedure. If you have to prevent the IOL pitting, make sure that you focus slightly posterior. The acoustic waves will break up the capsule well, and the threshold of antivitreous phase is slightly higher. From 1 millijoule, you may have to increase your energy to 2 millijoules. Yes, this is how it appears. So the capsulotomy size again, it should be as large as the pupil in the isotopic this thing. With the availability of new premium IOLs, if the patients of head off lenses are triphobic, make sure that the diameter is almost between at least 4 to 4.5 millimeters. And this capsulotomy, whatever we do, they tend to enlarge post-operatively. That has been studied around 32% within 6 weeks. They tend to enlarge. So post-operatively, they usually mild dose steroids is required for a week, and no use of antibiotic. If you suspect small amount of iritis, you can taper down the steroids. Pressure rise do happen. If you suspect after 5 hours, go with topical anti-medications. Otherwise, if it's not required. Majority of the times, vision do improve in this sort of patient. If the vision doesn't improve, we need to look in for the other causes why it's not improving. The complications are very rare, but still, as I mentioned, raised IOP, CME can be exaggerated, high myopic patients RD, and endophthalmitis is very rare, this thing, and more amount of energy iritis can happen. Thank you.
Thank you, Dr. Thank you very
Yes.
much for highlighting all these. Just one question, Ananth. Nowadays we have so many multifocal, trifocal lenses.
Yes,
There, what should be the size of capsulotomy?
that's what, sir. What I was trying to say is, see, we need to understand what sort of trifocal or what sort of EDOF we have implanted. We need to understand that we have a near addition component and where the peripheral rings are placed. So personally, I believe should be around 4.5 millimeter should be ideal
Okay.
for all these premium IOLs. Anything
Yeah.
lesser than that, intermittent vision might get affected and myopic vision.
Any questions from the house?
Yeah, that can be it. It's not a contraindication, so yeah.
Look, for doing YAG capsulotomy, patient needs to fix also. You want to hit in the right area. No point doing a capsulotomy in a non-pupillary axis. If you dilate the pupil too much, also you can may not have a centralized opening in these cases. So moderate sized pupil, as we talked about, should be used so that you can have a central opening in these cases. Unnecessarily very large opening not desirable also. So that is also very important. And too much of energy, too much of disturbance to anterior vitreous face going to create the complication is highlighted. We all know, especially myopic patients, you do have a higher chances of detachment, inflammation coming out, CME happening in these cases. So before doing a YAG capsulotomy of all these patients, apart from the picture he showed, it had a definite posterior capsular specifications, but there will be some other causes, maybe some other causes of decreased vision in these patients, especially diabetic patient, old age patient. There may be a macular scar, there may be macular edema. Patient may have a severe ocular surface problems. Those things should be ruled out before you actually damage the capsule. Because capsule is a one good area which separates the posterior from anterior space. It can be safeguarding various things. So unless you are very sure that is the cause of decreased vision and patient going to improve after capsulotomy, we should be damaging this capsule with the lasers. Yes, sir. Yeah, it can be used, sir. Normally we give a steroid for the first few days a week. If patient still has inflammation, you can continue. Normally don't require to give more than 1 or 2 weeks. And the anti-glaucoma medication along with that, both for a laser iridotomy as well as for a YAG capsulotomy, because pressure sometimes might go up in these cases. Thank you. Thank you very much.
Better to dilate and do. Better to dilate and do. No, one dose of T plus is enough. I think it will go until 6 millimeters. Your zone. Yeah, that's what. One drop of T plus will work out. Make sure that it's around
Don't
67.
dilate too much.
Too much of dilatation is not.
This is, very small pupil also very difficult to focus and you don't know where exactly you are hitting. And you have to know your machine. How much defocus, how much focus has to be done so that you exactly hit the capsule and don't hit the lens. Because in the past we have had, focusing problems and many lenses you have a multiple pitting and even a lens will crack also. And silicone lenses, they have a multiple, craters sometimes. So we have to be very, very careful hitting the spot in this case. Thank you again.
Yes.
Thank you, Ananth, all the speakers for making this session so lively. We are very thankful. The other people are already come to dethrone